you access to the recording as well. My name's Danny Kimball. I'm the Chief Marketing Officer here at O'Neill Insurance, and I have to say I'm so honored to be here with you all in this virtual space and to share the virtual space with our panelists. We do have a panelist. You can't, one member who you are unable to see right now, but Dr. Bricker is on the phone, so he will be chiming into the conversation as well. And I'd say, you know, we know that this year has been challenging for all of us. I think we're all in that space right now. And the past few months, our team has really been having virtual meetings with employers and small, mid-sized businesses throughout Ohio. And we've been asking this question in different ways. We've been asking, you know, what are some of the greatest challenges that you as in your business are facing today, and how can we help? And while there's many issues and concerns and things to overcome, I've been so inspired by the resiliency and this desire to persist and to keep pushing forward and to try new and alternative things and seek different solutions. And so, but along with that, one of the commonalities of the challenges that people were facing and businesses are facing is they were expressing this deep concern for their people in the workplace. And along with that, people risk management and the future of healthcare in general, and how will the their people's healthcare be impacted by this pandemic and moving forward. And so what we wanted to do is just bring together a group of subject matter experts that we have on this call today, and these subject matter experts fall in the fields of healthcare, group health insurance, and benefits technology, to bring their voices together to just share with us and give us a deeper understanding of where healthcare is going, what do we need to be paying attention to in regards to cost containment and improving our employee health plan, and then how can we integrate benefits technology into the mix. And help us really manage our benefits a little bit better. So I'm going to hand it over to our panelists and allow them to introduce themselves. I'd love for each of you just to take a minute or two to share with us who you are, some of the work that you're doing in the field today, and a little bit about your background. And Dr. Bricker, I'll go ahead and start with you.
Okay, great. Well, thank you so much, Danny and O'Neill, for having me, and thank you so much for everyone for listening in. This is Dr. Eric Bricker. I'm a general internist, went to medical school at the University of Illinois at Chicago, and did my residency training at Johns Hopkins in Baltimore. Actually, initially, before I went to medical school, worked as a hospital finance consultant, because believe it or not, doctors and hospitals don't know how to get paid, so they hire outside consultants to come in and show them how to do that. And actually worked on a consulting project at the Cleveland Clinic. So for almost a year, I lived there because they had us on site. And I was actually at the Reserve Square, which is connected to the Embassy Suites. It's kind of behind the Greyhound bus station, if you can picture where that is in downtown Cleveland. So I had the joy of being able to go through a Cleveland winter, and it was a fascinating experience. Went on to medical school and residency, and I subsequently started a company with some colleagues called Compass Professional Health Services, which is a healthcare navigation company that would be paired along with usually a consumer-directed health plan with an HSA or HRA, and our Compass Health Pros would help people actually navigate the healthcare system and their insurance, give people comparative price and quality information. That company was then subsequently bought by Alight Solutions, which is a 10,000-person spinoff, the HR outsourcing arm of Aon, actually. And so now I am creating healthcare finance educational videos on AHealthcareZ.com, which some of you may have seen. And I literally have about almost 100,000 people a month that watch these things, because I found in meeting with HR and CFO and a lot of brokers that kind of how the money works in healthcare and is oftentimes not sort of disclosed to you. And this is your money and your company's money and your employees' money. And so that's why I'm doing my best to try to educate everybody about, how it really works. And so I just am thrilled to be here today. Thank you for having me.
Thanks for being here. And I have to say, I love your videos, Dr. Bricker. They are so good, and I've learned so much from them. So thank you for doing that. Dave, you want to go next?
Yeah, thanks, Danny. Thanks for having me today. About Dr. Bricker, his videos are terrific. I recommend everybody do watch them. He puts everything in, as I say, Joe Plumber. Everything's straightforward. He doesn't speak insurance. He just speaks in facts and terminology we're all familiar with. So it's always great to see his videos. And also, Dr. Bricker, I worked at a bank when you're at Reserve Square, right across the street. So very familiar with that area. I'm Dave Conrad. I'm at Roundstone, and Roundstone is a underwriter, and we underwrite healthcare for about 500 employers around the country, and we have clients as far north as Barrow, Alaska, Southern California, up in New Hampshire, where I am today, and Southern Florida. So all four corners of the United States. We work with the middle market employers. You know, as few now as 5 employees on the plan to 1,000 or so on the plan. We help them self-fund. The Roundstone's headquarters are located in Lakewood, Ohio, which is just west of Cleveland, and we have about 70 employees there. Me personally, I cover the Cleveland area market, and I cover the Pacific Northwest, Alaska, and Oregon, and Washington, and Idaho, and then the Northeast up in New Hampshire, Maine, and all those states. But anybody on the phone, I work with O'Neill. They're a great agency. They're consultants. I don't consider them brokers at all. To me, a broker is somebody that just shops your rates annually, fully insured. O'Neill is a consultant to me because they actually look at your claims, they roll up their sleeves, they dig into what your cost drivers are, and they try to flatline your healthcare costs. I think everybody on the phone today, that's our goal, is to help you flatline your costs or even have your healthcare costs at normal inflation versus medical inflation, which is like 8 to 12%, some crazy number every year. We're trying to get everyone to purchase their healthcare and keep their costs flatline. Thank you.
Thank you. All right, Jason.
Hi, everybody. Thanks, Danny. And not much I can add on top of what Dave and Dr. Bricker started us off with. The relationship here with O'Neill has been wonderful. I look forward to sharing some good intelligence with you guys here today, specifically as it relates to how to improve the overall usability of your health benefits for your employees as well. But for me personally, I am with ADP. I sit in Medina, so not all that far from O'Neill and their kind of center of operations there. I've spent the last about 12 or so years working with finance and HR leaders, trying to put more money back in their pocket. And that obviously kind of serves as our end goal here today. So thank you, everyone. Thank you again to Danny and O'Neill.
Awesome. Well, thanks for being here. Eric, we're going to dive right in. But before we get into the specifics around cost containment, quality improvement, this question is for Dr. Bricker. Can you share with our guests today your thoughts on the trends in healthcare, primarily around the trends that are having, I'd say, the greatest impact on the employer-sponsored plans?
Yeah, so great question. And really what employers have really started to do in the past several years is moving much more in the direction of the direct provision of care. And if you want to improve the quality of care for your employees and you want to lower costs, then either one, there's really only 3 buckets that can happen. You either have to change the behavior of your employees, you have to change the behavior of the doctors, or if you don't want to change either of those, then you can do some fraud, waste, and abuse stuff on the claim side. But especially for groups that are fully insured and smaller self-funded groups that are, most likely on this call, then really, and this has been done by very large firms, but more and more mid-market and smaller employers are starting to do this as well. So what do I mean by the direct provision of care? It's around having an on-site, near-site clinic, direct primary care, or a second opinion program, especially for musculoskeletal services like joint replacements or spine surgeries. And so as you can imagine, it's the very large employers that sort of spearheaded this, and probably the most famous one is Walmart, where they've been doing their second opinion program for over 20 years now, where they require for joint replacements and spine surgeries, people to go get a second opinion. And the way that works and is helpful is that the second opinion is done by a physician who is on salary and is not fee for service. And they have a handful of centers of excellence that they use around the country for this. And actually, one of the centers of excellence that they use is the Cleveland Clinic, because all the physicians at the Cleveland Clinic are on salary. So in other words, that surgeon, that orthopedist or that neurosurgeon is not going to make any more or less money depending upon whether or not they choose to operate on the employee or their family member. And that perverse incentive in fee-for-service is really a lot of what the problem is. Now, there's some physicians out there that are like, oh, I can make more money if I operate. A lot of them don't think that way, but they still subconsciously are incentivized to sort of over-operate because of the fee-for-service reimbursement system. And so the Cleveland Clinic has done something really smart in that they've taken that away from the doctors and they put them on salaries. It's the same thing that they do at the Mayo Clinic in Minnesota. It's the same thing that they do at most academic hospitals. It's the way that it was at Johns Hopkins. And so small and mid-sized employers are starting to do more second opinion programs. It's absolutely something that is feasible. And so that's obviously, you don't do second opinion for all services. Musculoskeletal is probably the best place to start for that. And then the other area is in either on-site clinic, near-site clinic, or some sort of direct primary care relationship. And typically on-site clinics, as you can imagine, are for employers that are larger, that have larger concentrations of employees in one location. That might not be feasible for you, which is where a near-site clinic or direct primary care, where the employer is paying some sort of PEPM, sort of access fee, if you will, to gain access to those physicians. And the key to getting the employees to go to either the on-site or the near-site clinic is to have the out-of-pocket cost for that clinic, for that care, to be zero out-of-pocket cost. And sort of the company that spearheaded this, and obviously in Ohio you have a lot of manufacturing, but then you have a lot of other diverse types of businesses as well. There's a company in Wisconsin called Serigraph that actually makes auto parts for Ford and GM and Chrysler, and they make dashboards. And they're 1,000 employees, self-funded, so not huge, but not small. And they had an on-site clinic, and through the on-site clinic and some other things that they did, they actually kept their trend flat for over 10 years.
Wow.
John Torinis, who wrote the book about their experience, he was their CEO, and the book is called The Company That Solves Healthcare. And it is basically a play-by-play, and it's a great book in that it's like 200 pages. It's large font. It's a real quick read. Mm-hmm. And so it's been around for like 10, 15 years now. And so many of you probably have read this book, but if you haven't, I highly encourage you to read it. But he step-by-step talks about how he went about putting in place their clinic with a nurse practitioner at their site. And I've had the opportunity to speak alongside John on multiple occasions. And he said of all the things that their company did to improve quality and lower costs, the real secret was really that clinic. So without getting long-winded, I'll just kind of pause there.
Yeah, no, that's interesting. So I want to shift over to quality improvement and focusing internally on what the company can be doing inside their organization to enhance this. So we have a few groups on the call who are fully insured. We also have a few who are self-insured and some that are considering this transition between moving from fully insured to self-insured. So right. I was recently watching your video on quality improvement, and it was so good. But it was how employers and benefits advisors could really make a dent in the cost of their health plan simply by focusing on quality care. So from your experience, what are practical things and simple things employers can start doing today inside their organizations around quality improvement? And then second part of that question is, how does that correlate with cost containment for them?
So it's a great question, and it involves kind of two parts. It happens both inside of your organization and then outside of your organization. Because in order for quality to improve for your employees, there does have to be employee behavior and plan member behavior change. And that's what you as employers can most directly impact is the communication with your employees. And actually, John Torinas, in his book, The Company That Solved Healthcare, actually has an entire chapter on employee communication best practices. And he was actually shocked at how popular that chapter was.
Sure.
But, and at Compass, we had over 2,000 employer clients. And so I saw the full gamut of how employers communicated with their employees. And some were just amazing. And some, honestly, they only communicated with their employees about benefits for 1 hour a year in the fall during open enrollment. And that was it. And so it really is important to have an employee benefits, healthcare, health plan communication mechanism within the company to communicate information about how the employees can get assistance in terms of finding the highest quality health care in their area. Now, it depends upon the type of business that you are, but one, obviously, it needs to be throughout the year. It can't just be, once a year during open enrollment. And then two, and honestly, it can't just come through HR. That most people within companies, obviously it depends upon your corporate culture, who the employees listen to is typically to their direct supervisor or manager. And so the companies that have been very innovative in communication, they actually disseminate their benefits and health plan information out through their management channels.
Sure.
So one of our clients was Nebraska Furniture Mart, big retailer, and so they would have morning stand-ups at the warehouses and at the stores to talk about all sorts of things, whether it be which items were on sale or where to stock what in what place in the warehouse. And so they would actually do a model where the HR folks would disseminate the information to those managers who would be doing those daily stand-ups. And then once every couple of weeks, part of the daily stand-up was about employee benefits or healthcare or whatever it is that they needed to communicate out through the employer. We had a fair number of school systems as well, whether they be private schools or public schools. And again, through sort of faculty meetings was how they communicated out. And it wasn't coming from HR. It was coming from those direct representatives. Now, for some employers that had a dispersed employee population and were, heavily on the computers, et cetera, they would do it through email. But for some employers, email was a horrible idea.
Right.
So it really had to be customized to the employer setting. So it's like, okay, so fine. So there has to, and that really has to be done by the company itself.
Sure.
We never saw a situation where an outside company could come in and sort of create that because it's so unique to the organization. But I would tell you that at Compass, we would train people and help people to better navigate the healthcare system, be better healthcare consumers. So we had all of the best practices or sort of behavior modifications that needed to happen. But unless we could get that to the employees and their family members, then it was completely worthless. And so the companies that could effectively get it to the employees, and one of the things actually that Nebraska Furniture Mart did as well was about half their claims cost was from their family members, was from spouses. And so obviously if you're just communicating with the employees, you're like missing half your plan members. And so one of the things that Nebraska Furniture Mart did is they actually had a recorded webinar that they required the spouses to watch in order to be on their plan. Now, whether or not you require it or not, that's going to be up to you and your company culture, et cetera. But they would actually do dedicated, another company that actually made helicopters, believe it or not, they would have 8 p.m. meetings where the spouses would come in. So, whatever makes sense, obviously having some sort of channel for communicating with the spouses is also of utmost importance. Okay, that's fine. Danny, specifically about the quality issue, the issue then becomes, okay, well, what do you communicate? And typically, probably the lowest hanging fruit is getting connected with a primary care physician. And again, there have been many statistics on this, that half of the employees on a plan or half of the members on a plan typically do not have a primary care physician. And it is, finding one. Some employers will actually, they can't, say that there's going to be any out-of-pocket costs for their annual physical, right? Because that's covered at 100%. And some employers would even do additional incentives where they would say, hey, if you get your annual physical between January and September, then, we'll give you $500 on your HSA account, or we'll give you some premium discount or what have you, so you can do incentives on top of that. But that's super important because it's by having people go to a primary care physician that, the the large claimants, especially cardiovascular ones, those are prevented in the primary care clinic. You can't really prevent those once the person has a heart attack or stroke and are in the hospital, but it's catching the silent diseases of hypertension, high cholesterol, and diabetes. And invariably, when we did this with companies, at one construction company in Houston, they found 50 new diabetics. And they were freaking out because they're like, where is this diabetes coming from? And I said, you've always had those 50 diabetics. They just didn't know they had it. And so I all the time as an internist, I would see people with heart attacks or not being able to move the left side of their body because they had a stroke. And it was literally the first time they ever learned that they had diabetes.
Wow.
And what a shame is that? Wouldn't it been great if, 5 years before that their diabetes could have been identified and started to be treated so that heart attack or stroke could have never happened. And of course, Danny, to your point, an ounce of prevention isn't worth a pound of cure, and spending that money up front on the primary care is going to save you the $50,000, $100,000, $250,000 claim down the road. So if you're self-funded and you can actually look at your claims in more detail, a way to judge if you're being successful is you actually want to see your low dollar claims spend go up. You want to look at your claimants with less than $1,000 of spend, and you actually want to see the amount of money spent there. You actually want to see that go up. And we would see at Compass over a period of time, it usually would take 2 or 3 years, that the claims over $50,000 would come down, obviously proportion the amount of money that you were spending on the claims under $1,000, but you're actually catching that stuff earlier when your claims under $1,000 are actually going up. So again, let me pause there so I don't become long-winded and stop.
No, yeah, that was great. I'm glad you really hit home on that employee communications, and I'll share with just the guests today that O'Neill Insurance, we have all of the resources that you would need to build out an employee communications program. So we have access to all the carrier content, and we have our own content as well to help employers build that. And we do help employers build that. And I like your point, Dr. Bricker, around, every organization is very different. So manufacturing email may not be the best way to correspond with employees if you're in a manufacturing facility. Maybe it's having posters and information in the break room, or having breakout sessions, or like you said, stand-up huddles with the team and mentioning healthcare. But then in a tech company, it could be totally different, where video and email and them getting that all online may be beneficial. So I love your point on just honing in on employee communications. And for the employers on here, if you're looking for something like that, feel free to reach out to us, because we have all of the information to help you build that. But thank you for that. I'm going to move over to Dave. Dave, this question is for you. We get a ton of questions from employers as it relates to this transition from fully insured health plan to a self-insured health plan. When's the time to transition? All these things. So I love how you and your company at Roundstone support employees in this transition through a self-insured captive model. And that's a mouthful, right? Self-insured captive model. There's always questions around, what does that even mean? So can you break it down to the very basics of actually maybe step back and explain briefly the difference between fully insured and self-insured, and then what a captive is, what that process looks like when employers are considering moving from fully insured to self-insured.
Okay, well, thanks, Danny. So there's about 3 questions in there, so I'll try to be as brief as possible. So the difference between fully insured and self-funded is fully insured is guaranteed cost. You basically get an invoice once a month from your carrier, and you just send the money, and whether you have a lot of claims, a little bit of claims, it doesn't matter. And that carrier provides your network, it provides claims administration, and you rent the network. You go see the whatever doctors you want to. So it's all bundled up. Hit it like what we say, it's like hitting the easy button. Self-funded, on the other hand, we break it all apart, and you can now choose your network. You're not beholden to just Anthem's doctors or United's doctors or Aetna's or Cigna's doctors. You can actually create your own network. You can do things that Dr. Bricker just mentioned. You can choose direct primary care, and on top of that, rent a network. So you can kind of choose your network. You choose your plan designs. Anthem, you know, if you're fully insured, Anthem shows up and says, you've got to take this. Medical Mutual of Ohio says, here's your only choices. You're a 30 life group, take it or leave it. So you can choose your plan designs. And then the last piece is the funding's just different. Fully insured, it's one check a month. Whether or not you have the claims, you still pay the full ticket. Self-funding is a little different, whereby it's you get one invoice for your fixed expenses, and then as your claims are incurred, either once a week or every 2 weeks, you get an email and says, here's what your claims were. You know, we'll ACH or you wire us the money. So the key difference is that you either just, like some people pay their taxes, they overpay, and then they hope to get some back at the end of the year. Well, fully insured carrier is never going to give you a penny back. So you overpay every year and you'll get nothing back. But again, it's easy to do. Self-funded, it's flexible. You can choose any program, plan designs you want, and then you only pay for what you use. So you only pay for the claims that are incurred. Okay. So that was the first part of the question. What is a captive? I kind of shy away from that term because that's more insurance-ese.
Sure.
It's nothing more than a pool. So we're pooling together employers to purchase their health care like a Fortune 500. It's group purchasing. So I'm not a 30 life manufacturer or a 20 life accounting firm. I'm now part of a 50,000 life pool, and we're all buying our stop loss insurance, our catastrophic insurance together. We're all going to the network and negotiating a rate to administer our claims. We're calling Dr. Bricker and saying, hey, we want to use a concierge service. And it's not 20 lives. There's 50,000 lives here. So a Dr. Bricker or a Jason, a vendor, is going to give you better pricing. So it's group purchasing. So that's a captive. You know, in a nutshell, it's basically purchasing your healthcare like a Fortune 500 because we're pooling everybody together and then buying their services. And then the result is this captive or this pool. What happens is the fixed dollars that you pay for catastrophic insurance, whatever's left over at the end of the year, you get a check back. So if the money's not used, you get a check back, unlike fully insured. So, you know, Danny could share stories about, you know, this time of year, they're handing checks back because the pool did well. And so they're kind of like Christmas. They're going, by the way, you're self-funded and they didn't use all your money, you know, so here's some money back. So that's another difference. The process, it's really straightforward. If you're transitioning from fully insured to self-funded, basically in year one, O'Neill's going to recommend that you keep your plan designs the same. They'll try to, you know, obviously keep all the docs that you have today. So if you're with Medical Mutual and you want to use Cigna, you're not going to lose any of your doctors. So they're going to keep the plan designs the same. You're going to keep the same docs or physicians. You know, the providers will be the same. And the employees probably won't even know you're self-funded. The only folks that'll know you're self-funded would be the CFO and the HR person. And the HR, instead of paying that one invoice a month, they're going to go to one fixed cost invoice and either weekly or biweekly invoices to pay for claims as they're incurred. So really, it's going from one invoice to four or five, or 3 to 5. It doesn't matter. So that's the overall change. And the feeling, like I said, the employees don't know the difference. But I want to, before I finish this off, the key here is what Dr. Bricker said, and it was great. I was taking notes as he was talking. The key, if you're self-funded, so if I sit in front of you that are on the phone today, my last question to you is, before you move forward, is, are you going to be engaged? Because if you're self-funded and part of these pools, these employers are engaged in their health plan. What they're trying to do is let O'Neill in there to educate your employees to use the plan, I would say efficiently. I think Dr. Bricker used different words, but use the plan efficiently. You know, so let's, you know, if there's a second opinion available for free, let's use it. If there's a alternative generic, let's buy that. If there's a rebate on a drug that you're buying, let's work with a pharmacy that sends the rebate to the employer, that sends part of the rebate to the employee, so they're deductibles now. So we want the employer to be engaged in their health plan. We don't want, because if they're fully insured, they're working with a broker and not a consultant. The broker shows up once a year, delivers the renewal and says, take it or leave it. And they have great client services, but again, that's all they're doing. If you're self-funded and you're part of our pools, O'Neill's going to show up 4 times a year and say, here's your claims, here's what's driving your cost, and here's a solution. Here's a cost containment solution. And it might be, let's go with direct primary care clinics. I have many clients that are using direct primary care, that are engaged. There's a relationship with that physician. Good things happen when there's a relationship with their physician. So again, they're engaged in their health plan.
Yeah, that's great. I'd love your take on how the self-funded groups are doing amidst the COVID-19 pandemic. How has it worked out for captive members in regards to their cash flow and their overall control over their health plan?
So I want to make sure I'm saying this the right way, but it's been a cash cow COVID's been a good thing for the health plan, okay? Not for, I'm sure, the revenue overall, but to be self-funded in today's environment, in the COVID environment, has been literally a cash cow. We're doing our renewals right now, and the majority of our clients have seen their claims drop 30 to 40% because, those of you on the phone, I think everybody's from Ohio except for Dr. Bricker. DeWine came out and said that elective surgeries, you can't have them. And then when they started, the Cleveland Clinic started opening them up, or when DeWine said you could have them, it wasn't a tidal wave. The Cleveland Clinic is slowly, the University Hospital, all the hospitals are slowly letting people back. But again, for about 4 or 5 months there, claims were down 30 or 40%. So, and the other thing is, Dr. Bricker talked about, let's get a relationship with your primary care physician. So what we've seen is a spike in telemedicine. So instead of me going to see my doctor down at the main campus of Cleveland Clinic, recently I've had some health issues, and I do these Zoom calls. So I'm seeing my surgeon, I'm seeing my primary care, I'm seeing the nurse practitioner, everything's telemedicine. And so instead of my $500 to $1,000 visit, I'm getting a $50 bill. So, I can't say enough about it. So COVID, as bad as it's been for revenue, bad as it's been for not meeting people and generating new revenue, if you're self-funded health plan, we are seeing just very low utilization and high use of telemedicine. So it's kind of been a cash cow. It's been a really, really good scenario for them.
That's interesting because the fully insured groups don't get the opportunity to really feel that, right? Too much.
No, I mean, so you're fully insured. There's if you're fully insured right now, Medical, Mutual, Anthem, Aetna, guess what? They're the insurance company. They're sitting on billions, not millions, billions with a B. They are printing money right now because you're fully insured. You're still sending them that full ticket. You're still sending them all that money to cover claims if they should happen. So think about a fully insured carrier. If their losses or loss ratio is 60 or 70%, and then they have 15% administration expenses on it, right? They're supposed to send you, according to the Affordable Care Act, you guys should all be getting checks for 15% back of your health care, right? Because they're supposed to send, if you're a certain size, they're supposed to send you back whatever's left over. I want to, let's check in with everybody in January or February and see if anyone got a check back for 15% of their health care. That's not going to happen. But those of you that are on the phone, they're self-funded, that money never left your checking account. You didn't have those claims. That money is sitting, in your health, in your checking account. You never spent it. So.
One more question for you, and Dr. Bricker, and even Jason, you may want to chime in on this one as well. Why do you think, and it's a loaded question, why do you think employers are overspending on health insurance today?
So I'll go first, Dr. Bricker, and then you can chime in. So I think if you're fully insured, you're overspending. Fully insured's hitting the easy button, and it's just, I don't have to think about it, and I don't have to contain costs, even though you'll turn to us and complain that, hey, this is like the third most expensive thing on my, line item. This is very expensive, but they don't have to think about it. So they're overspending because they can hit the easy button and stay fully insured. But what they're doing is they don't know what they don't know. So they don't know that if you're with United, Aetna, or you know, any of the Blues, Anthem, Cigna, that you're overspending on your pharmacy by 30%. So if you're with Welldyne, Optum, Express Scripts, Caremark, those pharmacy benefit managers own the network, or they're closely affiliated, or there's a financial relationship there. So I can tell everybody on the phone, if you're with one of those pharmacies or pharmacy benefit managers, you're overspending on your healthcare 30%, but you don't know that. You don't know that every time that your employee or spouse goes out and gets a Humira, that you know, you as a healthcare provider, you as the employer, are spending $8,000 on that drug every month, and MMO or Anthem is cashing in a coupon for $1,000, and they're not sending you that $1,000. They're pocketing all that. So you know, that to me is the biggest or the lowest hanging fruit right now, or what's kind of going on. The overspending is everyone's overspending. If they're with the Blues, United, Cigna, Aetna, Anthem, we call them BUCAs. If you're with one of those, you're overspending on your pharmacy by 30% guaranteed. And the other thing is, if you're fully insured, I know you're overspending. Just it's easy because you're hitting the easy button and you're not really engaged in your health plan and you're not looking at long term.
Dr. Bricker, do you have anything to add to that?
Yeah, I think because we at Compass, because we grew to about 300 employees, and we made the transition from fully insured to self-funded at about 120 employees. And our smallest group that was self-funded as a customer of Compass was 30 employees. And and we had tons and tons of groups that were like 80 to 200 employees were self-funded. So you're talking 160 to 400 plan members. And I think one of the challenging things is that understanding like the stop loss quote and the stop loss process can be kind of confusing. And so obviously O'Neill has a lot of expertise around that, as does Roundstone. There's a guy, I have no connection to him whatsoever. It's called Stop Loss with Spencer. It's so funny. If you go on YouTube and you search stop loss insurance, he's the only person that shows up. Because who in the world would go onto YouTube to look up stop loss insurance? And he's put together all these videos that very easily explain how stop loss quotes work, et cetera, et cetera. So I would just say that would be a good place to start with the education process.
Sure. Yeah, that's good. All right, let's dive into technology a bit, Jason, and technology as it relates to employee benefits, because we have a number of HR professionals on the call today, and I know technology has been a huge focus of theirs, primarily just in the last year, really, because of everything happening in the world right now. So question for you, open enrollments are coming up for many, they're right around the corner. How can employers utilize technology to support like a successful open enrollment and benefits renewal season this year?
It's a great question. In our experience, there's really three main ways that technology can be leveraged specifically around the open enrollment that you're either just starting or just about to get started in. And the first one is something that Dr. Bricker spent a couple minutes talking about, and that is simply communicating with your employees. You know, we talked about what your company culture looks like, whether it's those stand-up meetings with the manager at the furniture company. Obviously, technology can't really help a whole lot with that, you know, but depending upon what your culture looks like, getting the messaging out to your employees is plain and simple the best way that the technology can help speed that process along for you. Whether that's email, whether that's automated text, whether that's push notifications through the mobile app that your HCM provider gives you. There's a lot of ways that communication can get pushed out to the employees. The second big way is actually enrolling online, doing away with paper. I mean, especially in today's COVID environment, we're seeing a lot of that with our middle market clients, trying to eliminate having your representative from O'Neill come in the office and shake hands and talk to all your employees, and then have them all come into your office as the HR practitioner and drop off the paperwork, right? Technology is to the point now where it can be very much like a consumer-driven process. We're trying to, ultimately turn most employee engagement experiences into a consumer atmosphere where they can see the different plans side by side, and they can see what their monthly premium is going to look like. They can see what the benefits are. They can compare them and actually complete the enrollment online. So that would be the second big one. Mm-hmm. And then the third big way that technology can help support open enrollment is simply from a tracking standpoint, right? If you're doing things paper-based now, you probably have a spreadsheet going, and every time somebody brings in their forms to you, you mark off, yep, we received this, and this from that person. Oh, we still need their dependent verification stuff. They forgot to bring that in. So simply from tracking it, during open enrollment, tracking is huge, but even when outside of open enrollment, tracking things like wellness plans or other things like that, simply helping keep everything straight is another big aspect of it.
Yeah, so it keeps everything a little bit organized, right?
Right.
You kind of spoke to this already, but what are some of the benefits just of using a technology platform, an HCM provider, to help administer the benefits? How do you see small mid-market companies really using those effectively right now?
At the end of the day, the end benefit to using an HCM provider to help administer the benefits is going to be very different than what Dave or Dr. Bricker talked about, right? There's not much we as your HCM provider can do to help drive down claims cost and implement a direct-to-provider network and go self-insured, right? There's not much we can do there. A lot of the savings and benefits we're going to provide are what we would call soft savings. They're making your life easier as the CFO, as the HR leader, to administer that plan, communicate with your employees, keep track of everything. So there's a lot of small things that add up to a lot of time savings. So things like carrier connections. Now, again, depending upon the carrier, certain carriers and the size of your company, it may or may not be available to you. But if you're using a unified HCM system, we can completely eliminate that go-between where you need to send information off to either O'Neill or directly to Aetna, to UH, whoever the carrier may be, so that in real time, all that data is transmitted back and forth. And not simply who the employee is and what plan they've elected, but even getting down into things like invoice reconciliation, depending upon the support you need around that area. There's a lot of tools and great reporting that are available from higher end HCM providers to tackle that. Things like your end of the year reporting. Obviously people hear ADP and, oh, you're the payroll guys, right? Well, no, we haven't been just payroll for 30 years. And at the end of the year, sure, we're going to send out your W-2s, but bringing benefits and wrapping that into your HCM solution, your ACA reporting is now done for you as well. So there's a lot of different things that can go on, whether it be total reward statements. If you want to share with your employees, hey, your salary is $60,000, but this is what you actually cost the company. The easiest way to do that is again, through your HCM system. So, and then lastly, just reporting and analytics. If there's one big takeaway I could share with everybody here, whether it's around your plan mechanics, self and funded versus fully insured, how you're managing the back office side of benefits, is simply know your data. And especially as Dave talked about when we just asked for one takeaway from him, when you are fully insured, you have limited visibility into those claims. The self-insured crowd, you obviously have a lot more visibility into your claims and what the spend is going on. But moving into the people side of it, simply know your data, know your numbers, know how many people have signed up for a plan. You can look for trends depending upon your HCM provider or depending upon how you're working with O'Neill. You could benchmark your cost, your benefit cost to other O'Neill clients, to other ADP clients, right? That is the number one area we see that companies can stand to improve is they simply don't know what they don't know. And that technology is a great tool to help solve for that problem.
Yeah, I'd agree with that. I think that's been a huge conversation lately, especially now that people are adapting to change a lot quicker given the pandemic, that they know technology. There's a solution there with technology. And I think sometimes the pain point is jumping into a new system and learning a new process and trying to get everything integrated very quickly, right? So they can effectively administer their benefits from a technological standpoint. But I see the benefit, and Dave brought it up as well, is like knowing the data, the claims analytics, getting access to claims. You brought up benchmarking, and O'Neill has access to tools and resources to support some of those benchmarking and claims analysis as well. So, pulling all of it together, I think is just a huge opportunity to really leverage the data that we have in front of us and available to us, and organize it in a way that makes sense for our employers, to understand, where their spend is going, and then also get a pulse on the health of their employees, right? And that's where that communications piece comes in, and that quality control comes into play, is like get a health or get a pulse on the health of the employees, so that the communications can be tailored around ensuring that you're navigating them to the or kind of pushing them to the right direction for healthcare, right? So that's good. I do want to open it up to questions. So if you have any questions, feel free to drop those in the chat. That's for our attendees. And while we're waiting, I want to go around one more time to each of you. And if you could just share one key strategy that you feel employers should consider today to improve their employee health plan and contain costs. And I'd say the simpler the better. Like, what's one simple strategy employers should consider to improve their employee health plan and contain costs? Now, this can be around quality of healthcare, it can be around cost containment or benefits technology. So I'll start with you, Dr. Bricker.
Yeah, it would really be on the communication piece. It costs you very little. And the only thing I'll add to it is that it's an iterative process. So don't think you're going to come up with the perfect communication plan up front. It totally requires trial and error. That's to be expected. It's probably going to take a few years to figure out the right way to communicate with employees. So if you don't hit it out of the park on the first try, that's totally normal. Just keep at it.
Sure, that's great. Dave?
So I've got one. If you're self-funded today, I would say that one is if you're with a carrier-owned pharmacy benefit manager, and it would look like Welldyne, Optum, Express Scripts, Caremark, or Ingenix if you're with Anthem. If you're with those, leave those and go to an independent pharmacy benefit manager that is passed through, meaning if there's any rebates, you as the employer get them or your employee gets them. So go to a pass-through PBM. So if you're self-funded today, if you're fully insured today, I'm just gonna have to plug our program, look at going self-funded with a pool, no matter your size. So that would be my two key strategies for saving costs.
All right, great. Jason?
I'll reiterate what I wrapped up my last question with.
Yeah.
Know your data, know your numbers. It's impossible to improve and work on things we don't know. Whether that's your overall cost, whether that's number of people and how they enroll, whatever your key metric and your KPIs you're trying to hone in on first, make sure you understand it. Every day we're talking to people that they think they need help here, but they don't, because they don't know what they're even doing and how to go about starting off that process.
Sure. Thank you. We did have one question come in, and this one's for you, Dave. This is from Patrick. He says, how does Roundstone partner employers? Does that create limitations in plan design? Discuss catastrophic claims, and are those employees lasered out?
So I think you're a little bit hard to hear, but so how does Roundstone work with employers?
Partner with employers.
So we.
I'm sorry. Partner employers. So in the pool.
Oh yeah. How do we pull them together?
Yeah.
So basically, it's just based on the renewal date. So if you're a January 1st renewal or a July or someone in between there, we give the employers a choice. Which pool do you want to join? So, and that's after they pass the underwriting. So we typically deny about 20 to 25% of all of our applicants for once we underwrite them, we say, they've got some current high claims. They need to really work on something to contain costs or be more engaged, whatever it is. There's like a holding period, but we'll decline to quote them. So once they pass that underwriting, we put them in either the January or July pool. So that's how we pool them together. And O'Neill can share the statistics with them afterwards of what the pools look like. We'll tell you what industries that they're in. They're heterogeneous pools. So there's white collar, blue collar, for-profit, nonprofit, and these January and July pools. So that's how we partner them together. How does a catastrophic claim work? That's a great question, because there's a lot of fallacies around how modern self-funding works compared to the old days. The old days, if you had a $1 million claim and you're a 30-life employer, you as the 30-life employer would have to front that $1 million and then go to your stop loss carrier and say, hey, I'm only supposed to have $50,000 worth of risk. I need the money back, and it doesn't happen that day. Modern self-funding has a couple of beautiful features. Number one, it's called simultaneous reimbursement. So that same $1 million claim today, you will get an email on a Monday saying, hey, there's a $1 million claim. However, you have stop loss. So you're responsible for the first $20,000 of it, because you have a specific, or your catastrophic limit. It depends. Every firm can have their own, but let's just say you're a 30-life employer and you say $20,000 is enough risk for me. So you get an email saying you owe the first 20. I'm getting an email that same day saying, hey, we need the next 980. So you as an employer out of that, you just pay your 20 and we pay the next 980. So we pay half, some of that through the pool and then the other half through reinsurance. But that's the first thing I want to make sure that we're all on the same page, is you're only liable for that first 20. And then there's what's called aggregate insurance. So it's insurance for all the claims. And so all the claims to the plan below 20,000. So you can buy that on a monthly basis. So you can have it where not only do you not have to worry about claims above 20, but then they'll come to you and they'll say, you don't have to worry about any more than 40,000 or 23,012 cents worth of claims a month. So there's two types of insurance that most employers on this call, middle market employers get. They get to cover the catastrophic, and then they get it to cover frequent claims below their deductible. So that's called aggregate reinsurance. So that's how it works. Modern self-funding has all these little tools and bells and whistles in there, because we know that you're a middle market employer and you can't fund $1 million claim and wait to be reimbursed. So we have these protections in there for you, so it's not financially prohibitive. And also, they didn't even mention this. What if there's a term called a laser, which is a very large claim. And so if you have a plan member that next year is going to go to the Cleveland Clinic and get a lung transplant for $650,000, well, we have it's called a triple cap. So meaning if your deductible for your plan is $20,000 and that claim pops up in this plan year, the next year the most that we can laser or have a deductible on that person for is $60,000. Even though we know that claim is going to cost $650,000, the pool will take care of most of that claim. But we want you as the employer, we'll be honest, very honest with you, we want you, the employer, to feel a little bit of heat there. We don't want you to be responsible for the 600 and really, hurt you. But we want you to, instead of paying 20, we want you to pay that extra 40. And why? Because we want you to talk to Dr. Bricker about a center of excellence. We want you to, do something, because you're going to feel a little bit of pain. We want you to take a recommendation when Ty or O'Neill sits down with you. They're going to tell you, okay, here's where the highest quality of surgery is. That's something that, Dr. Bricker hit on a little bit, but, Walmart, they send all their backs to the Geisinger. Who's ever heard of the Geisinger? Nobody on this phone probably. Well, guess what? The Geisinger, that's all they do is back surgeries, right? So you can either send them to the Cleveland Clinic where that guy or gal, that physician might do 20 a year, or you can send them to Geisinger where they do 1,000 a year, right? And so the quality's higher, the readmissions are less. And at the end of the day, you as the employer are going to pay less. So we want you, again, I know I'm super long-winded, Danny, but we want you to feel a little bit of that high cost claim in the following year, So when they come to you with a recommendation, you'll communicate to the employee, and you don't have to as the employer. Let O'Neill Insurance talk to that employee, to that spouse, and say, hey, your plan has got this great strategy. We want to make sure you get the highest quality of care. So, let's have a second opinion and go here where that's all they do. And a fact that Dr. Bricker, the book he recommended that they throw out there is backs, and I believe, musculoskeletal cancers and hearts. I believe in 30%, around 25 to 30% of those are misdiagnosed nationally. Maybe Dr. Bricker can hit on that, but I've seen that stat more than one time, that a lot of these major surgeries are misdiagnosed unless you go to a center of excellence, and then they can tell you for sure because that's all they do.
Thank you. That was good. It was a big question, so thank you for hitting all the points. All right, I do want to be respectful of everyone's time, and so again, I appreciate you all jumping on this call today. Thank you to my panelists for giving your time today to serve our guests on this very, very important, critical topic to discuss. I will be following up, just for our guests, I will be following up with an email with some information that we covered today, and also the recording if you would like to look back on it as well. So thanks again, and I hope everyone has a great afternoon.
Thank you.
Thanks, guys.
Thank you, everyone.
Thanks, everybody.